today. I'm sorry I'm having some video problems, but it's really good to be with you. First of all, I want to thank you for conducting this conference and for your devotion to addressing the stigma around mental health. I think we all know that stress is everywhere in our society. No demographic is immune. UNT Dallas is acutely aware of these issues, both in the community we serve and the students we serve. We are a uniquely hyper-local state university. We focus on an area that is 95% Dallas and the surrounding communities. It's where our students come from, and a lot of our students are so ambitious to change their lives. That's how they've gotten here in the first place. And so we have a mission that an incredible buy-in to our mission that is inspiring to all of us. I would say reducing stress among our students, our staff, and faculty is an important part of what we do. We provide a very welcoming environment for our students. One of our main goals this year, as it has been, is taking care of our students and our employees. I'm happy to say that UNT Dallas is now one of the largest employers in Southern Dallas. That was a goal when we were originally founded 11 years ago. We became an independent university 6 years ago. And no other university focuses on urban Dallas students the way we do. Nearly 100% of our students come from those areas. And sometimes they bring a stress from their urban upbringing to our campus. And so we provide strong counseling staff, advising staff. Our advising ratio is 1 to 250, which is very low for a university because it's important. We ask a lot of our students, and students ask a lot of us. I don't know if you remember reading Ta-Nehisi Coates' Between the World and Me, but he had his upbringing was in urban Baltimore. And as he was growing up, he didn't even realize how stressful his environment was. Going from home to school, he had to think about which route he's going to take. Going from one floor to another to school, he had to think about, what's the safest route. And when he finally ended up at Howard University, he said in the first few months, he just felt the stress leaving his body. And that's what we're trying to do at UNT Dallas. We want the stress to leave our students' body. And so what you're doing is extremely important. Self-care is very much emphasized on our campus for our employees, for our staff, but also in our community. We not only recruit students from a very specific community, which is hyper-local, but our community service is very local as well. So I'll give you an example. We have a police institute, and we're working with the police department to train officers on how to de-escalate situations. If you remember the George Floyd incident, which I know all of you are acutely aware of, but those officers who were just standing around, not intervening, so we partnered with Georgetown University Law Center to bring the best training in the country, which is called active bystandership, which you saw in Minneapolis is passive bystandership. But what we're bringing is active bystandership, where officers are trained to intervene when a colleague is not doing the right thing. We also understand that mental health is such an important component, not only to crime, but bad police behavior. almost always a bad actor in law enforcement is suffering from some kind of behavioral or stress situation that is dictating his or her behavior. And so we work very hard to try to de-escalate situations. Our partners at the Meadows Mental Health Policy Institute have been very helpful to us. Just around the corner, there's a substation, a police substation. And Meadows Mental Health Policy Institute worked with the city, with Parkland, with fire and rescue paramedics, because the area had the largest number of 911 behavioral calls of any substation in the Dallas area. And so what they did is put together a program called Right Care, which is why what you're doing is so important, because policy matters. Policy around how do you address these issues, community police issues, to reduce stress, to reduce incarceration. And so what they did is created, whenever a 911 call occurred, a police officer, a paramedic, and a trained social worker would go to the scene. And if it was nonviolent, if it was just, and which most of them were, as you know, then the paramedics and the social worker in particular would work to de-escalate. And guess what? It worked. I mean, in most rest of the city, if a police officer shows up just himself or herself, they can't immediately de-escalate the situation. Off to jail they go. And then Parkland has to come in on the back end of that, but they're in jail. It's not ideal. But with this special approach, which again is really dictated by mental health professionals like yourself, it changed. And now the city is expanded into Northeast. They've taken Right Care to Northeast. They're going to take it to other parts of the city. On the front end, it's a little more expensive, but on the back end, it's much less expensive. So, you know, I think at UNT Dallas, we believe that we believe in self-care. And I'm so appreciative of the great work that Dr. Lacey and her folks are doing. But we have professors in other areas, staff members in other areas who are working very hard to address the stigma around mental health and to de-escalate situations, to reduce stress. And I'll just say one other thing. Partnerships matter, because you can't do anything alone, really. And one of the things we were concerned about was that police suicides, first responder suicides, are really rising in Texas. And so we looked around, we did a kind of a landscape analysis, and who's doing anything about this? And there was no university taking the lead, so we took the lead. We worked with Meadows Mental Health Policy Institute. We found a strong legislator who would carry a bill to create first responder networks. So it was just an idea. It didn't cost anything, but it grew out of this concern to reduce stress among first responders, because we know that if it's not addressed, it could have effects on our citizens. Senate Bill 64 and its sister bill in the House passed both houses. The governor signed it the other day. So UNT Dallas, Meadows Mental Health Policy Institute, and the TCOL, we are going to stand up first responder networks so that officers can use an app and test themselves privately to see if they're suffering from unusual stress. And then there are solutions in this app that will suggest what they can do about it, where they can go discreetly for assistance. So it takes them out of the HR mode at their departments. And this was done in coordination with them. So I'm happy to say that as of September 1, this is going to be law. We got a nice grant from the Perot family to stand up the pilot program, Pilot First Responder Network in North Texas. But this is why universities are important. This is why the work that you're doing is important. This is why partnerships are important to address the issues, because we can't do it alone. And sorry, I'm a little long-winded. Sorry, I was a little late to get on. I had trouble maneuvering the technology. You're actually lucky you can't see me because I've got a face for radio. But anyway, I really do admire the work that you're doing, and I wish you luck in today's session.
Thank you so much, President Monk. I don't know if you realize, or if everybody realizes, but under your leadership, our university has grown the fastest since you've been with us in 2015, and we so appreciate all of your leadership. And you are right, those partnerships have been just really phenomenal, and the funding to move the work forward. So we appreciate you so much. Thank you.
Yeah, thank you so much.
Indeed.
Take care.
Yes, sir. Have a great day. So welcome everybody. We so appreciate President Mung giving you the next steps. We're already, our campus is working to move forward. I have just a few housekeeping announcements. I am Constance Lacey. I serve as the Dean of the School of Human Services at UNT Dallas. I want to thank our project manager, Ms. Kiala Jocks, for going ahead and moving us forward while we navigate these technical waters. I'd like to extend, I did this yesterday, but it goes without saying that it's important, to President Monk's point, to always acknowledge that we can't do this by ourselves. This symposium is the result of the brainchild of many committee members, one of which, Ms. Gloria Jackson, is the representative from Eastfield College, our partner with Dallas College. Ms. Carmen Andujar with the National Hispanic Latinx Mental Health ATTC, Ms. Maureen Nichols, who is really the underwriter for this project with the South Southwest ATTC, Dr. Don Tyus with the African American Behavioral Health Center of Excellence. I want to name them. They're also our sponsors. It's in the tab at the beginning. Please go in and take a look at what they're doing. Click on their icons and connect to their websites. You'll be really, really encouraged to know that work is taking place. If you have registered, you should be able to log into your links. We know that we have set up for you to do a survey after you complete the class that you've pre-registered to get into. We're having a little bit of a hiccup with that, but we plan on emailing you opportunities to complete your surveys. We want you to get your CEUs, and we are excited to get your feedback. That's going to be important. So we'd like for you to work with us on getting those surveys in, and we'll probably send you opportunities to give feedback for your experience on yesterday as well. Okay, that's housekeeping. If there's anything I've missed, I'm sure Ms. Jocks will put it in the chat. So from time to time, look at your chats to make sure that you have the most up-to-date information. I am so excited to introduce our next keynote speaker, Dr. Luis Torres Hostos. And he is not only a part of the Hispanic Latinx National Mental Health TTC, and he'll talk to you more about that, but he also serves as the Dean and Professor of the School of Social Work at University of Texas, Rio Grande Valley in Edinburgh, Texas. And I'm a social worker, so woo, social work. And all the rest of you all are meaningful. We love you. You make a good work, but you know, I just have an affinity to social work. He assumed his role in August of 2020 and rapidly integrated into the university local and binational communities of the Rio Grande Valley. And so it looks like he is very much into the importance of community collaboration. His area of expertise in the social covers the social determinants of health, social justice, health equity, and community engagement. So without any further ado, I would like to introduce Dr. Luis Artures Hostos, a new partner in Change. Take it away, Dr. Hostos.
Thank you so much, Dr. Lacey. Can you hear me? Are you able
Yes,
to
sir,
hear me?
we can. Yes,
Wonderful.
sir.
Thank you so much to you for the invitation, and Dr. Mung for his words. You know, I've been doing a little bit of research on UNT Dallas and preparation for my talk this morning, and very impressed with what you've been doing all along, but especially under the leadership of Dr. Mung. And I understand you were relatively recently designated as a Hispanic serving institution. 52% of your enrollment is currently Hispanic and 27% African American. So almost 80% of your students are from minority communities, and that's how we impact our communities long term. So kudos to all of you for the fantastic work that you're doing. Let me share my screen. I am going to, I have multiple screens, so sometimes it takes a little bit of time. So you should be seeing a blue screen, and then in a moment you'll see my slides. There you go. Can you see that?
Yes, sir.
Wonderful. So you know, I wanted to talk a little bit, and a shout out to all the social workers out there. A couple have already posted on the chat, and to yourself, Dr. Lacey, you know, for the affinity as well. I think if there was ever a time our society needed social workers, it is now. You know, the past year and a half has really brought to the forefront all of the issues that we work on arduously as social work practitioners, as social work educators, as social work administrators. So this is our time. And I think that when we look back, you know, I've always said that, you know, I'm actually not a social worker by training, although I am by marriage. And I'm a psychologist by training, but I've had a foot in social work and a foot in psychology and a foot in public health for most of the last 30 years. And I've always said social work has had a PR problem. You know, you stop the average person in the street and you ask, you know, what's a social worker, and you're likely to get a response about child welfare, you know, the folks who take your kids away. And so you know, the past year and a half and the way that social work has come to the forefront in the middle of everything that we're going through, I think we'll look back at this many years later and say this was the moment when people truly understood what social workers do. So but today I'm going to talk about health equity. So I was given discretion in terms of what to cover in the keynote address. And I wanted to talk about equity in behavioral health, and particularly about breaking down barriers to accessing mental health and substance use treatment in Hispanic Latino populations. But a lot of what I'm going to talk about actually applies to other minority communities as well. So I have been down in the Valley now for a year. I moved here with my family, my wife, who's a social worker, and my daughter to the Valley in July of last year, of 2020, in the middle of the pandemic, from Houston, after having spent 12 years at the Graduate College of Social Work at the University of Houston. And talk about, you know, going from the frying pan, out of the frying pan and into the fire. You know, at that moment, things in Houston were bad related to COVID, but the Valley was leading the country in terms of every COVID indicator. So I got here and quickly got to work, and thankfully we've been able to make great progress. We have one of the highest vaccination rates in Texas and actually in the country, and you know, we're looking very carefully at the latest developments because we're not out of the woods yet. I'm also in a mixed race relationship. My wife is African American, and my daughter, we have a 16-year-old daughter who refers to herself as Latina. So I have a deep interest and commitment to what happens in both Latino, Latina, Hispanic, and African American communities, and I work hard with both communities. I'm originally from Puerto Rico, and in Puerto Rico we say el que no tiene dinga tiene mandinga. You know, he or she who doesn't have dingo has mandingo, to old African tribes. And it's our way of saying colloquially that Puerto Ricans are a mix. You know, we are multiracial, and we trace our ancestry to the African continent. We trace our ancestry to Europe. We trace our ancestry to many parts of the world. So these are two communities that are near and dear to my heart. So let's jump into it. So I want to talk a little bit about health inequities first, to make sure that we have a common understanding about what I'm referring to. So when we talk about health inequities, we're talking about systematic differences in the status of different population groups when it comes to health. And I'm going to be talking about health and mental health and behavioral health together. So systematic differences in the health status of different population groups. So you take different groups and you do fancy statistical analyses, and when you control for all the factors that could be impacting their prevalence to various conditions, their morbidity, their mortality, you end up with differences that you are struggling sometimes to explain. You dig a little deep and the struggle isn't so great. We can understand why it's happening. But there are these differences that we've spent really billions of dollars in research to try to address, and we're making progress, but at a very slow pace. These inequities have significant social and economic costs, so they matter. They matter in terms of life expectancy. They matter in terms of quality of life. You are all familiar with apps where you plug in your zip code and it tells you what your life expectancy is. And I'm looking at the chat. My apologies. Right. I have a little bit of a difficulty accessing the chat because I'm in presentation mode. So if you have a
We'll
burning
we'll
question, just yell it out.
we'll
You'll
raise
want to.
up our hands for you. We'll raise
Thank you
our
so
hands.
much.
Mhm.
Thank you, Dr. Lacey. Or just unmute yourself and jump in. So it matters. I was talking about these life expectancy calculators that you plug in your zip code and it tells you how long you're expected to live. And that's just wrong at so many levels. How long you're going to live, and of course the quality of that life shouldn't matter. Shouldn't be determined by your zip code. But that's what's at the core of these health inequities. There are social factors, and we know that these social factors like education, employment status, income level, gender, ethnicity, all have a marked influence on health and behavioral health. And we also know that all countries, whether they're low income, middle income, or high income, have wide disparities in the health status of different groups. And overwhelmingly, the lower you go in the socioeconomic ladder, the higher the risk that you have of poor health and poor behavioral health. So this is tied to economics. Now, I want to pause for a moment, and I want to talk a little bit about the distinction between inequity and disparity. And these are terms that we actually use interchangeably, and they are, to be sure, interdependent, but they are distinct. They're related but distinct. When we talk about disparities, we're just talking about a difference, a lack of parity of some kind. Disparity is a term that many researchers like. We like to use the term because it's kind of a sanitized, antiseptic term, if you will. And as researchers, we sometimes want to remain objective, and we don't want to wade into murky waters. But I'll tell you, when you research and you work on the kinds of issues that we work with, we'd have no choice but to get our hands dirty and wade, sometimes neck deep into murky waters. So we have to stop using the term disparity and start using the term inequity. And the term inequity implies not just a difference, but a state of unfairness, right? There is a reason why there are differences in morbidity and mortality between different groups on a variety of conditions. There is a reason why, if you're Black or brown, over the past year and a half, you've had a much higher likelihood of contracting COVID, of being impacted by the mitigation strategies to combat COVID, of getting sicker when you actually get COVID, and hospitalized and ending in the ICU and even dying. There's a reason for that. There's a reason why, when you look just yesterday, there was a report about how life expectancy in the US decreased in in 2020, it didn't decrease equally for all groups, right? For Blacks and African Americans, the decrease in life expectancy due to COVID was higher. So these are inequities. These are unfair situations in our society that we must address if we practice from a social justice lens. Practicing, whether you're doing research or you're doing clinical practice or you're doing community practice from a social justice framework, demands that we label these differences and inequities as inequities, and that we continue to address them. So we have to continuously work to promote social, environmental, political, racial, all kinds of justice. So I'm forcing myself. I'm well trained like most of you, and in being objective, but I'm forcing myself from moving away from the term disparity and more using the term inequity. Let's call a spade a spade. Let's talk a little bit more about these inequities. Brock Chisholm, the Director General of the World Health Organization, back in 2013, said without mental health there can be no true physical health. Right? We've known David Satcher said this also. 20 years before that. Right? There can be no physical health without mental health. So mental behavioral health and physical health go hand in hand. Dr. Satcher actually hold on, I'm advancing over here. Oops, no, there you go. Dr. Satcher, in the famous report of the Surgeon General back in 1999, talked about health and behavioral health and inequities. And he talked about finding ways to overcome the barriers of stigma, but first acknowledging that stigma exists, right? Most of us here are probably trained as providers of one sort or another. And as providers, part of what we do is do an assessment and come up with a diagnosis, whether it's a diagnosis of a community situation or of an individual patient, right? And diagnoses are important. They're important for billing purposes. They're important to match the condition the client is experiencing with the best treatment possible. But we also have to recognize, and this is also part of practicing through a social justice lens, that diagnoses are labels and that labels carry stigma, right? So Dr. Satcher talked about acknowledging and finding ways to overcome these barriers of stigma. I'm going to talk a little bit more about this later. He talked about building public awareness about mental health and effective treatments, right? Many people don't go for treatment because they don't know that treatment exists or they don't know that treatment is available. So we have to do more on that front. He talked about addressing the shortage of providers, serious shortage of providers, and the lack of training available for many community helpers who could potentially impact a person's health, right? We've made progress here as well, increasing the workforce, diversifying the workforce, bringing to the forefront many community health workers or promotores y promotoras de salud. This is one of the areas where we've made the most progress. Ensuring the delivery of state-of-the-art treatment. There are many more evidence-based interventions for various communities today than there were 22, 23 years ago when Dr. Satcher was talking about this. Tailoring treatment to the age, the gender, the race, the culture, the context of the patient, of the individual. Facilitating entry into treatment. SAMHSA for many years has had this no wrong door philosophy that I'll talk more about it as well later. And then finally, removing financial barriers. Even there, we have made some progress with the Affordable Care Act and other reforms. Unfortunately, the previous 4 years, it felt like we were sliding backward and backward and backward, and that slide has stopped, and hopefully we'll regain the momentum. Now, this was in 1999, and I would love to tell you that we had made incredible progress in every single one of these areas. And while we have made some progress, there's still a lot of work to be done. And I'll touch on more of these points later. And then the Robert Wood Johnson Foundation finally says about health and mental health equity, behavioral health. Equity means that everyone, it doesn't matter your zip code, it doesn't matter what language you speak, it doesn't matter the color of your skin, it doesn't matter where you were born. everybody has a fair and just opportunity to be as healthy as possible, right? And that's not pie in the sky. That's achievable. It's achievable in many places, and it's certainly achievable in the United States of America, the wealthiest nation in the world, where we spend more per capita on healthcare than any other country in the world, right? We're just not doing it right. We have to figure out how to do this better. And one of the ways in which we can make sure that those investments pay off is removing the obstacles to health. Things like poverty, discrimination, and its consequences like powerlessness, lack of access to good jobs with fair pay, quality education, housing, safe environments, accessibility to healthcare, food insecurity, housing instability, all those things that we call today the social determinants of health, right? I love to take a jab at my medical colleagues when we're presenting together or working together, and they thankfully take it in the spirit in which it is intended, which is the spirit of solidarity. Most of you will get this because I'm assuming there's a lot of social workers in the audience, but you know, I tell my medical colleagues that social work has been talking about social determinants of health for over 100 years. You go back to the settlement house movement in Chicago, it was all about housing instability, food insecurity, loneliness and isolation, poverty, etc. Social determinants of health. But it wasn't until medicine started talking about this maybe 15, 20 years ago that all of a sudden it got sexy. Now everybody wants to talk about social determinants of health, and everybody wants to do something about social determinants of health. And I tell my medical colleagues, I'll take it. We'll take it any way we can, as long as every now and then you give us a little recognition that as a scientific discipline and as a profession of practice, social work has been talking about this for a very long time, and more than talking about it, doing something about it, right? So access is important, and I'm going to keep talking about access and insurance rates and what we can do from a policy point of view. But in order to achieve health equity truly, it requires more than just access. We have to address these underlying social determinants of health. The neighborhoods where people live. Many of us live in neighborhoods that are not safe, that you can't go out, that don't have parks or even sidewalks where you can go and walk and exercise and be physically active. Many of them are overrun by pollution because of chemical plants or other types of pollutants that are in nearby. Many of us live in communities where we don't have ready access to health or health care. Many of us are stuck in occupations or job conditions that are hazardous to your health and don't have adequate coverage. And this is one of the things that we saw over the last year and a half about the pandemic that really made a difference. We're going to look at that in a moment. There are tremendous income and wealth disparities. It's no secret that, over the last 15, 20 years, the gap between, it's been growing forever. It's always existed in the US and continued to grow. But the size of that gap between the wealthy and the poor has become astronomical, and not just in the United States, but throughout the world. And it's fueling instability here and abroad. And of course, the education gap. We're doing tremendously in having more minority folks enroll in higher education, and both Latinos, Hispanics, and African Americans are enrolling in college at much higher rates than in previous decades. But we don't still know if they're graduating at those higher rates. We have to do more to make sure that they don't just enroll, but that they get to the finish line. And there's reasons why getting to the finish line when it comes to college for Hispanics and African Americans is a little bit tougher. They're more likely to enroll in a 2-year community college than in a 4-year college, more likely to live at home instead of living on campus, more likely to go to school part-time rather than full-time. We know that all those things impact who gets to graduate and who graduates faster. So we got to pay very close attention to those 4, 5, and 6-year graduation rates, because it was only about 4 years ago when we kind of surpassed, and we crossed that threshold where more minorities and non-minorities were enrolling in higher education. So we're at that 4-year gap mark right now. So we have to look carefully at the 4-year graduation rate, 5-year next year, and then the 6-year graduation rate to see if we're really doing right by our Hispanic and African American college students. This is a visual way of representing this idea of equality versus equity. I'm still trying on this equity lens, right? I'm sure that you've all seen these. You probably maybe even saw them in the course of this presentation. There are 3 ways of depicting the same thing. You know, you see the one with the baseball scene on the left, your left of your screen. You see 3 individuals on the left that are on equal size boxes, and 2 of them are still able to see the game, and then the third one on the right hand side, a little bit shorter, still can't see the game. And then on the right side of that same graphic, the boxes have been redistributed. The taller individual didn't need a box to begin with. The middle individual only needed 1 box. And the short guy, which would probably be me, I'm a short Puerto Rican, on the right-hand side, got 2 boxes and can now see the game. The same concept in the middle with the folks who are trying to reach the apple, and on the right-hand side with the bicycle, right? At the top, everybody gets the same a size of bicycle, and for one individual the bicycle is too small, for one individual the bicycle is too big, for another individual the bike is just right, but then for one individual the bike doesn't work at all because the individual is in a wheelchair, right? That's equality, and we love to talk about equality because we love to talk about everybody getting an equal chance. Well, you know, we live in a society where not everybody gets an equal chance, and the sooner we acknowledge that, the better we can address it. And then you see at the bottom side, and you know, the shorter individual child looking on the extreme right now has a smaller bike. No change was needed for the person next. The taller individual now has a much larger bicycle, and the person who was in the wheelchair now has a wheelchair type of bicycle so that they can still enjoy the cycling, right? So we talk about equality as trying to fit needs, as trying to redistribute the resources that we have. But at the end of the day, when we talk about equality, we're just addressing the symptom and not the problem. I like to use this one that maybe some of you have seen, which is a variation of the basketball scene. The first 2 panels are the same, you know, and the one on the left, they're all in the same side box and one can't see. In the one in the middle, the boxes have been redistributed, and so the shorter individual can now see the game as well. But the one on the right-hand side, the barrier has been removed altogether. All 3 of them can see the game without any support, without any accommodation, because that wooden fence that was there to protect them from foul balls or from straight balls coming at them has been removed and replaced with a transparent fence, right? So the root cause of the inequality, of the inequity has been removed, right? And of course, it's much harder in the kinds of things that we work at than with baseball analogy. But the idea is to go beyond simply band-aid approaches that solve the symptom in the moment, and to go deeper and try to get at the root causes that cause these inequalities, these disparities. So let's talk about Hispanics and Latinos a little bit, because that's the group that I spend the most time working and thinking about, and about behavioral health inequities, right? And here I want to pause for a brief moment. You know, I'm obsessive about language. You know, my daughter hates it because I like precision with language, and I just want to always make sure that we're speaking the same language, referring to the same thing. So I'm using the term Hispanic, Latino, interchangeably as well. But again, they mean slightly different things. And as our society continues to evolve and progress, many folks may no longer refer to themselves as Hispanic or Latino, right? There are many terms that we use to refer to ourselves, and I'm going to touch on those in a moment. But here, I just wanted to clarify, Hispanic usually refers to language and those whose ancestry come from Spain or Spanish-speaking countries in the Americas. Latino usually refers to geography, specifically to Latin America, which includes the Caribbean, Mexico, Central and South America. And there are other terms that are emerging. The latest one is Latinx. It's been in use for several years now, and Latinx emerged as a way to be more inclusive and more self-ascribed. Hispanic is criticized because it's a government-imposed term. Latino, Latina, like many words in Spanish, is a gendered term. When you're Latino really refers to males, Latina refers to females. And so if you use one or the other, you're not being inclusive. If you use both, Latino/Latina, you're not being inclusive of people who might be non-binary. So we're always trying to broaden the scope of our inclusiveness. And so now more and more people are using Latinx, right? Now, I always caution my students, social work, psychology, psychiatry students, to be careful not to jump on bandwagons too soon, because then we end up doing what we're trying to avoid. We don't want terms that are imposed on us, but if we refer to people, for example, as Latinx, that still haven't embraced that term, we're doing the same thing. The Pew Research Center released a report last August in 2020 about the use of the term Latinx, and what they found in their survey was that 76% of Latino adults, 76%, just over 3/4, have never even heard the term Latinx, and that only 3% were using it. Now, of course, young adults age 18 to 29 and college grads were more likely to have heard Latinx and to be using the term. They tend to be more woke. My daughter tells me not to use that term because it's falling out of usage. I'm always a decade behind. I remember a couple of decades ago, I used the term fat, P-H-A-T, with my younger nieces and nephews trying to be cool. And one of my nieces, who was like 12 or 13 at the time, said, "Theo, that is so 5 minutes ago." I'm always behind in the coolest lingo, right? But young adults, particularly those that are exposed to higher education, tend to have a much broader awareness of these kinds of issues. So I think it's great that we have terms that are more inclusive. What I'm trying to say is let's not rush, and let's just ask people, how do you refer to yourself? One of the things that we know from many surveys is that most Hispanic, Latino, Latinx individuals refer to themselves first by country of origin. I'm Mexican or Mexican American, I'm Puerto Rican, I'm Cuban, and only secondarily do they use a pan-ethnic label like Hispanic, Latino, Latinx, Chicano, etc. So always ask, how do you refer to yourself? Going back to behavioral health inequities, we know that older Hispanic adults and Hispanic youth are especially vulnerable to what we call immigration stressors or acculturation stressors, right? They're especially those that are first generation immigrants, but even those that are second generation immigrants. The first generation immigrant is the first to come into the new country, right? The first to migrate. The second generation immigrant is the one who's born here of parents who are immigrants. And we talk about the 1.5 generation as well. So signifying people who came very, very young and have grown up here. And there's some research specific to that group. But folks who are immigrants or live in families that still have immigrants are exposed to tremendous stressors. As you know, over the last 4 years, the previous 4 years, the Latino community, particularly the immigrant Latino community, has been was under assault. You know, with the insistence on building this wall and the criminalization of immigration and lots of stressors. And we know that stress associated with immigration and acculturation has gone through the roof in the Latino community, even in people who are not immigrants themselves. We also know that 1 in 10 Hispanics, that only 1 in 10 Hispanics with a mental disorder use mental health services from a general care provider, and only 1 in 20 get it from a mental health specialist. I'm going to present some more data on service utilization in a moment. So we got a lot of work to do to bring people into treatment so we can tackle these behavioral health inequities. We know that Hispanic Latinos are more likely to report poor communication with their health provider. And this is not just about, oh, I speak Spanish only and my provider speaks English. Even Latinos who speak English fluently report poor communication with their health provider. And there's a lot of research into this. And one of the things that we look at is provider biases, right? Sometimes providers make an assumption based on the last name of a patient or based on the fact that somebody may speak with an accent, right? Which always is remarkable to me, because I think everybody in the United States speaks with an accent. It's a different accent wherever you go, even if they're speaking in English. But providers make assumptions about where people come from, how educated they are, how smart they are, how well they're going to be able to understand me when I'm discussing their condition and their treatment plan. You know, even assumptions about how well they're going to be able to engage in the treatments that I recommend. So providers may recommend simpler treatments that might be less effective. So this poor communication with health providers has real consequences. As I was saying, bilingual patients in particular are evaluated differently when interviewed in English as opposed to Spanish. And when there is a mismatch, this becomes magnified. And that can lead to misdiagnoses. It could lead to mistrust on the part of the client or the patient. And it can mean prematurely ending treatment. They're just going to come and not come back. Latinos are more frequently undertreated. Only 1 in 4 Hispanics with a mental health condition received treatment in the past year versus 2 in 4 for non-Hispanic whites. So this problem of undertreatment is a bad problem across the board, right? Non-Hispanic whites aren't doing that great. Only 50% are getting treatment versus 25% for Hispanic. So we have to do better across the board. I'm going to present some more up-to-date data about 2020 and the pandemic in a moment. And of course, there's the issue of insurance. You know, Hispanics have the highest uninsured rate of any racial ethnic group in the United States. 18.7% for Hispanics, 6.3% for non-Hispanic whites. And of course, in Texas, because we are phenomenal and we like to be the best at everything, even at the things that are not great, the rate of uninsurance in Texas is even higher across the board, and particularly for Hispanics. So the uninsured rate in Texas is in the mid 20s% for Latino, 26, 27%. And you know, in other parts of the country that participated in Medicaid expansion and the Affordable Care Act exchanges, et cetera, the number of Hispanic Latinos that were uninsured dropped. That's why that percentage nationally is 18.7%. Some of you might remember that before the Affordable Care Act, it was about 33%. About 33% of Hispanics did not have insurance. The Affordable Care Act tremendously helped the Latino community. In Texas, we still have a long way to go. What are some of these barriers? Okay, so what is it that gets in the way of getting people to get behavioral health treatment so that we can actually address these behavioral health inequities? The insurance issue is one of them. I was just talking about them. The access to healthcare, being able to pay for healthcare, is a big barrier. It's not the only one, but it's an important one. Poverty rates. You know, Latinos have a higher poverty rate than other groups. 15%, 15.7, almost 16% of Hispanic Latinos live in poverty versus 10.5% for all groups in the US and 7.3% for non-Hispanic white. We talked earlier about not knowing where to go, right? You just don't, sometimes you don't even know what questions to ask. You don't want to talk about what's going on with you because you don't want people to think that you're strange or that something really, really is wrong with you. So you don't talk about it. And people might notice that something is off or that you need some help, but they don't know where to go to access these services. So we have to do more to promote the services that are available. I already talked a lot about general stigma in society about mental illness, but specifically cultural stigma in society. Latinos are very family-centered, a very family-centered group, tight-knit. We like to keep secrets, in the family, and we have this expression, "La ropa sucia se lava en casa." You do your dirty laundry at home, right? Or you don't air your dirty laundry is the English equivalent. So the idea of going and telling somebody what I'm struggling with is scary to many people because it almost feels like they're betraying their family. They're afraid about what the family is going to say. They're afraid the family might even find out. When I started graduate school 30 something years ago, we were all not required, we were strongly encouraged to go into treatment ourselves. As I said, I'm a psychologist, a clinical psychologist by training, and we were all strongly encouraged to go into training. They gave us lists of providers that saw trainees at a decreased cost. So I went into therapy for the first time, and people in my family went crazy about, how dare you go and tell somebody else about our family secrets and this and that and the other. And so I had to convince my family that it wasn't about them and that I was never talking about them. Of course, it was all about them and it was all I ever talked about. But to keep them at peace, I had to lie to them. Another barrier is language, right? And with language, there's the obvious English-Spanish barrier. Many clients, particularly more recent immigrants, but even long-term immigrants that have lived all their lives in what we call an ethnic enclave. This is true of other groups, not just Latinos, but if you're Hispanic and you move to a Latino Hispanic ethnic enclave where every store you go into, they speak Spanish. The providers, the clinic, local clinic, everybody speaks Spanish. At the local government office, everybody speaks Spanish. At the bank, they speak Spanish. So you don't have a need or an urgency to learn English, and many folks never did, right? So there are many older patients who've been here for a very long time, and they still speak no English or very little English. So there's that English-Spanish dichotomy. But there's also increasingly folks from in indigenous communities in Mexico and in Central America, and particularly that are coming to the US. And for them, Spanish is a second language, right? And they're not incredibly proficient in Spanish. So that creates, even a larger challenge, because you can't just call a language interpretation bank and say, hey, you have anybody that speaks Quechua, right? So they might be available, but it's not as easy as saying, I need a Spanish interpreter if you're a provider who doesn't speak Spanish. And then in terms of language, I also wanted to make a distinction about the language of mental health, right? We're all highly trained, and there's a lingo that we use that sometimes is foreign to our Latino clients in English and in Spanish. I'll give you a great example. In English, we talk about psychiatric disorders, right? And many of us are savvy enough to not even use that language. You talk about, mental health conditions or mental health concerns, because the term disorder turns people off. Well, in Spanish, the literal translation is trastorno, un trastorno de salud mental, which is an even uglier word, for lack of a better term, than disorder in English. So you tell a patient that they have a trastorno mental, a mental health disorder in Spanish, and they're likely not going to come back. They're going to run for the door. You're never going to see them again. So we, instead we talk about problems with your nerves, or, we talk about anxiety or depression, which people can relate to. And that helps open up a conversation, right? So we have to be mindful that our technical professional language doesn't become a barrier as well in engaging with clients. Other barriers to accessing mental health, the lack of culturally tailored services. You know, many services, many interventions have not been developed with, by, or for minority communities. That's starting to change. We're seeing more and more evidence-based interventions that were developed specifically for minority communities by minority intervention developers, or other interventions that are being tailored or adapted, right? Slightly different terminology there. When you talk about tailoring services, you know, it might be about delivering them in Spanish instead of delivering them in English, or making sure that the interventionist, for example, is Hispanic. When we talk about adapting, we're really talking about looking at the core components of that intervention and adapting it to the culture and the context of the client that we're serving. That's a little bit more involved and often involves working with the intervention developer directly. We have a lack of culturally competent, grounded, whatever term you're going to use, culturally humble, culturally informed mental health professionals. And that's an area that's, we have made progress, but we continue to lag behind. That's why training opportunities like this one are very important. We are, you know, the growth of the Latino community is going to continue. And there's always going to be more Hispanic patients or clients or consumers, whatever term you're comfortable with, than Hispanic professionals, right? So we can't wait for the provider workforce to catch up, and we have to also bring in non-Hispanic providers and train them on working with these communities, which is part of what you're doing today. There is a shortage of bilingual. So again, the issue of language, shortage of bilingual or linguistically trained mental health professionals, difficulties recognizing incipient signs of mental illness. I'll talk about this later in the slide on what to do about it. We have to do more to train our communities, all our communities, faith-based communities, families, community-based organizations, on what to look for. How do I know? What are some signs that somebody that lives in my house, somebody that I work with, somebody that I'm friends with might need some help? And then, you know, figure out where to help them get that help. And then there are problems identifying psychiatric symptoms when the chief complaint is somatic. One of the things that we've known for decades is that Hispanic patients are more likely to express their psychiatric distress in terms of somatic complaints. You know, they talk about fearing of having a heart attack, of pressure in their chest all the time, instead of talking about anxiety, for example. So we have to dig a little bit deeper. Always, any good assessment begins with a full physical exam. So we have to work jointly and collaboratively with our primary care colleagues, but we have to unpack what is physical and what is behavioral health. Legal status, I mean, that goes without saying. Large numbers of the uninsured are folks that have irregular documentation status. These in particular were under tremendous assault in the previous 4 years, and it was kind of a hiatus. You know, it's important to have strong borders and to protect our laws, our immigration laws. All of that is important. It's also important to have some humanity and some compassion for folks that are trying to escape horrible conditions in their countries of origin. And we should be able to do both. It shouldn't have to be one or the other. And then, of course, acculturation. Once they get here, they struggle to integrate into our society. So these are some barriers that perpetuate these inequities. We can't talk about anything that I'm talking about. I know that I'm running out of time, so I'm going to speed it up a little bit. But we can't talk about any of this without talking about COVID. And this is a recent CDC Morbidity and Mortality Weekly report on the February 2021 racial and ethnic disparities in the prevalence of stress, worry, mental health conditions, and increased substance use among adults during COVID-19. And in a nutshell, Hispanic adults reported a higher prevalence of psychosocial stress related to not having enough food or stable housing than did adults in other racial and ethnic groups. Again, the social determinants of health. And we also know that they experience a higher burden of morbidity and mortality than other groups. African Americans were obviously at the top in COVID morbidity and mortality, and Hispanics were right behind them. And and when you look at what was causing the issues with COVID, the spikes, the increases, it makes sense, right? So Latinos, for example, were at increased risk for serious illness if they contracted COVID-19 because of the high rates of underlying conditions, diabetes, asthma, hypertension, and obesity compared to non-Hispanic whites. They were more likely to be uninsured, as we've just seen, and to lack a usual source of care, a medical home, the access barrier that we talked about. They were more likely to work in the service industry, which means that they were at higher risk for losing their income during their pandemic or having to continue to go to work. They were also in industries where they couldn't necessarily work from home. They were more likely, still are, to live in multi-generational families or low income and public housing, which makes it difficult to social distance or to self-isolate when you tested positive for COVID. And finally, they often worked in jobs that were not amenable to telehealth, telecommuting, and they use public transportation and higher rates, which put them at risk for exposure to COVID-19. So there, remember that the whole distinction about in disparity versus inequality. There are reasons why those inequities exist. This was a report from the Kaiser Family Foundation in 2020 that I was talking about. This is from that same morbidity and mortality report. If you look here at the rates for current depression, current suicidal thoughts, and substance use increase or initiation, Hispanic Latinos, which are 1, 2, 3, the fourth line, total white non-Hispanic, black non-Hispanic, Hispanic Latinos, and other. This is a randomized sample. The rates of Latinos are through the roof. So 40% of them reported current depression, as measured with the Physician Health Questionnaire 8. 23% stated that at some point in the past 30 days, they had seriously thought about killing themselves. So this is not just passive suicidal ideation. At some point in the last 30 days, they had thought about killing themselves. And almost 37% showed a substance use increase or initiation. So the question there was, have you started or increased using substances to help you cope with stress or emotions during the COVID-19 pandemic? And substances included alcohol, legal or illegal drugs, or prescription drugs taken in a way not recommended, not prescribed by the doctor. So, COVID did not impact all groups equally, as you can see here. And this is not the only report that's talking about this. And then, despite all of this picture that I'm presenting, there are still gaps in treatment. So here, this graph from the same paper that I was showing you, the Morbidity and Mortality Weekly Report, is called Double Jeopardy: COVID-19 and Behavioral Health Disparities for Black and Latino Communities in the US. And here what you have is, when you look in the first column, substance use disorders, almost 90% of individuals 12 or older who meet some criteria for substance use disorder are getting no treatment. When you look at mental health, any mental illness, 67% are getting no treatment. When you look at serious mental illness, severe and persistent mental illness, those 18 and older, 44% are getting no treatment. When you're looking at co-occurring any mental illness with a substance use disorder, of those 18 and above, 93% are getting no treatment. And when you look at major depressive episodes in the 12 to 17 age range, so adolescents, 62% are getting no treatment. So we are failing our Hispanic communities and our African American communities when it comes to bringing them into treatment.
Dr.
And just to,
Torres,
yes, ma'am.
Thank you so much. We are so sorry because this is such rich information, but our time, we're at the end of our time for this one. I will tell everybody that you will be presenting at our next breakout session. So is it possible for us to be able to connect people so they can ask you questions? We have
Sure.
Dr. Torres and Ricky I'm sorry, Ricky Romero. I don't know why my tongue won't work today. I apologize. I did not mean to slay Mr. Romero's name. Philip Ortiz and Dr. Nancy Herrera will be speaking 10 and 11, and Dr. Torres. This is so rich. I've been making notes. You've seen my head go back and forth. I've been taking notes, and you've got rich conversation in the chat. One of the questions is if you would share your links or your information. And we want to continue the conversation. So let's all log off here, log back on at the 10 o'clock breakout session. Thank you so much, Dr. Torres. Everybody get my hand. Put your hand clap up there. Thank you,
Thank you
sir.
so much. I'll be happy to share
Okay.
the slides.
Thank you so much. Bye-bye.